Great. Thank you very much, and good morning, everybody. It's really an honor to be here. I had the opportunity to meet Chris Tamar late in 2001 when she invited me to a meeting in Munich, and I have long admired her dedication and passion to eliminating colon cancer throughout the world. And so I commend her very much for her efforts, and everybody in this room for their efforts. I come from, this is a transatlantic meeting, but I'm coming from the Pacific side of the United States. So I thought I would begin with a photograph of the Pacific Ocean. We're a large country that spans the two oceans. And this is a beautiful area and a wonderful place to be contemplative. And there I am being contemplative on the beach, looking at the Pacific Ocean, thinking about this conference and remembering that there will be 1 million new cases of colon cancer this year, over 500,000 deaths. It remains the second leading cause of cancer death in North America and Western Europe. And we have evidence that screening can have an impact, that it can reduce mortality and prevent many cancers. The red portions of this slide show why this conference is so important. You see that North America and Western Europe have the highest rates of colorectal cancer. This is in men, but the same applies to women. In the United States, colorectal cancer remains an important cause of cancer among all of the cancers. And then among the GI cancers, it is, of course, the most common cancer. And this year, there will be over 140,000 new cases of colorectal cancer in the United States. We've learned a lot about risk factors for colorectal cancer, and we will have some talks today related to identifying high-risk individuals. My focus will be on the sporadic average risk individuals who still account for the majority of colorectal cancer that we see in this part of the world. I want to highlight some new guidelines that were published during this past year that apply to population screening in the United States. There were two guidelines, one produced by the American Cancer Society along with the Multi-Society Task Force on Colorectal Cancer, which I chair, and the American College of Radiology. The second guideline is from the United States Preventive Services Task Force. And they looked at the variety of screening tests, and both groups concluded that screening can be effective and can work. And there are some differences among these tests that they recommended. And the guaiac fecal cord blood test, both groups recommended, but for the first time, both groups suggested that we should be using a more sensitive form of the fecal cord blood test. The fecal immunochemical test, which is a newer test, both groups have recommended, provided that this test was also sensitive enough to detect at least half of cancers with a one-time test. And the stool DNA test, which is a very new test, was recommended by one of the groups but not by the other because they felt that the evidence was lacking at this point. Nevertheless, the review of these studies suggested that any of these tests could be effective. The American Cancer Society guideline differentiated between tests that were designed primarily for early cancer detection versus those that can detect both early cancer and cancer precursor lesions. And these tests included sigmoidoscopy, colonoscopy, and CT colonography. And the difference between the two guidelines was that the American Cancer Society guidelines suggested that CT colonography could be used or could be recommended for screening. The U.S. Preventive Services Task Force did not. So I'd like to take these guidelines and highlight a few of the issues surrounding applying these in populations. And one of the issues with the stool-based tests is highlighted on this slide. You see that if the tests are administered one time, that the sensitivity for detecting cancer ranges among these tests, but you can see that it is less than perfect as a cancer detection test, and that's one of the reasons these tests need to be repeated on a regular basis. If the goal of screening, though, is actually cancer prevention, we would like to identify advanced precursor lesions, and you can see that less than half of the cancer precursor lesions are detected with the stool-based tests. Based on the current guidelines, the recommendation is not to use the standard fecal copioid test, which is commonly used here in the United States, because it doesn't meet that basic sensitivity requirement of detecting half of cancers. So that leaves a variety of other tests. When we consider what is involved in implementing these tests in populations, which is one of the goals of this meeting, we can see that the guaiac FOBT has the advantage of having very low initial costs, can be performed at home, and requires few specialized resources. But there are a number of limitations of this test. As I've shown you, the one-time sensitivity is very limited. The test needs to be repeated at 1 to 2 year intervals, and the adherence to this repeat testing is really unknown, but it's complicated in real-life clinical practice. In addition, we have some evidence that the adherence to receiving colonoscopy for a positive test is uncertain as well, and that many physicians do not necessarily recommend colonoscopy, and many patients may not accept colonoscopy for a positive test, rendering the test ineffective. So therefore, this form of testing really requires that these elements be considered carefully if these tests are to be offered. In addition, the potential for cancer prevention is relatively poor, as I pointed out, because precursor lesions are not likely to be identified. The newer fecal immunochemical test has the advantage of being specific for human hemoglobin, can be performed at home, and has a relatively low initial cost. But it's uncertain right now what the additional benefit will be compared to a less costly sensitive guaiac test, and so further studies probably needed. And there was a new study from Germany that was just published a few months ago that compared various versions of this fecal immunochemical test, showing that there's quite a bit of variation in the tests that are out there in the marketplace right now. Hence, the performance of these tests remains uncertain. The ideal number of stool samples remains uncertain. And the adherence, again, for colonoscopy for positive tests and repeat testing for negative tests is unknown. Also, the potential for cancer prevention remains unknown. So there are a lot of questions that remain to be answered regarding this test. We have, though, I think, with colorectal cancer, a unique opportunity among the cancers. And that is that we understand that the development of neoplasia is probably related to genetic, environmental, and lifestyle factors. But that if we can identify patients with important cancer precursor lesions and remove those lesions with colonoscopy, as shown with this polypectomy, we can eliminate many cancers. And that represents an exciting opportunity. And that's why the American Cancer Society guideline suggested that the structural exams of the colon should be offered preferentially to the cancer detection tests. And really, there are the 3 tests, all of which have very high sensitivity for detection of cancer and variable sensitivity, but good for the detection of advanced precursor lesions. So I want to talk about 2 of these tests and some of the issues involved in implementation, because again, that really is part of the theme of this conference. For CT colonography, we have a new technology that's very exciting that can detect high-risk lesions, but we're not sure which patients should necessarily be referred to colonoscopy, and that has a tremendous impact on the cost. There's general agreement that if polyps greater than 6 millimeters are detected, that they should all be referred, but it's unclear what should be done about smaller polyps. We have problems with quality of the test and interpretation. There are studies that have shown that different radiologists have different interpretations, so inter-observer variability is an issue. We have the awareness now that flat polyps, which may have serious pathology, exist in Western countries, and the ability of CT to detect these lesions may be limited. We're not sure. The current iteration of the CT colonography requires a very good bowel prep, and if you need a colonoscopy, you would have to have a second bowel prep unless you were able to get the colonoscopy on the same day. That's an important issue. There's radiation exposure with CT scanning, and although low resolution CT can be performed, there is some concern about the cumulative effect of radiation in average risk individuals, and in some countries that is not acceptable, so that this radiation exposure could lead to some additional cancers. There's the risk of finding things beyond the colon. When you do a CT scan, you see more than the colon, and that leads to some additional cost and some additional risk. And finally, there's uncertainty about the appropriate intervals for performing these tests. So implementation of CT, although it's an exciting technology, there are still a number of important issues. What about colonoscopy? We have information from the original screening colonoscopy studies that we published back in 2000 that has now been enhanced by many studies throughout the world, the largest experience being in Germany, where I believe close to 2.5 million individuals have now been screened with colonoscopy in an organized screening program with data collection. And what these studies have all shown is that when colonoscopy is performed in average risk individuals, 5 to 10% will have advanced neoplasia, and 0.5 to 1% will have cancers, and most of those cancers are early cancers. So we have evidence from the cohort studies that have demonstrated feasibility and safety. The efficacy is still uncertain. We haven't really demonstrated what we would like to demonstrate for sure, that we're reducing both incidence and mortality. We think we are, and I'm very hopeful that in Germany, because it's an organized program, that we will have an opportunity to see what happens in a country that implements colonoscopy and the effect it will have on mortality and incidence. The quality in practices is uncertain, and we're going to talk a little about quality today for all of the screening programs because this really applies to all. In program performance, in other words, are patients that are offered colonoscopy accept it? Do they have it? Is still uncertain. But the potential for cancer prevention here is extremely high, and I think that's why this has been embraced in the United States. We do know that it's not perfect, that there are cancers that are found after somebody's had a colonoscopy with polyp removal, and this could be due to new fast-growing lesions, incomplete removal of polyps, but probably the most important factor are lesions that are missed at the baseline colonoscopy, which means that we have to pay a lot of attention to the quality of the examination if we're going to be using these tests in screening. We also know that this is the highest risk procedure, and this is a compilation of studies that have been published over the last few years showing the complication rates of colonoscopy. And bleeding occurs primarily with polypectomy in up to 3 per 1,000 cases. Perforation is less than 1 per 1,000, but it can occur either with polypectomy or without. So there's some risk associated with this. And another reason that we need to be very careful about the quality of colonoscopy, because the colonoscopy is the final endpoint of each of the potential screening programs. So as we think about how we're going to implement screening throughout the world, since colonoscopy is our final endpoint for screening tests, we really have to be aware of the quality of our colonoscopy. Is it being used appropriately? Are we getting high quality exams to the cecum? Are we missing low rates of important lesions? And are we completely removing lesions? And do we have a low rate of adverse events? And really, this comes down to quality. In the United States, the screening rates are now approaching 50% for average risk individuals, but you can see now that the increase in rate has really now been driven by colonoscopy. There's a significant drop in both fecal occult blood test and sigmoidoscopy, which is why I haven't really mentioned sigmoidoscopy much. Is it having an impact? Well, we think it is. This is some data that was published a few years ago that I've extrapolated, but we see that the original recommendations from the American Cancer Society for screening with FOBT and sigmoidoscopy had little effect. But when Ronald Reagan had colon cancer in 1985, we see that there was a drop in the rate of left-sided colon cancer, but not in the right side of the colon. I think this highlights the importance of publicity and education that Krista Marr emphasized in her comments, that it can have an impact. The first colonoscopy screening papers were published around 2000, and we're now seeing in the United States a significant decline in the incidence and mortality of colorectal cancer. So I think it is making a difference. The challenges we face today as we talk about these topics, I think, are the programmatic adherence that I mentioned, which is still uncertain, and the barriers, both to the initial test and also to the follow-up test if we're going to be using a program that requires follow-up tests. And so We're going to be talking about novel programs to increase awareness and overcome barriers. Resource limitations are important in many parts of the United States and throughout the world. Disparities in our ability to, in groups that are receiving screening and underserved populations are important. And we'll be talking today about national approaches as well as novel local approaches, and hopefully learning from each other about this. And finally, as I mentioned, the quality of all programs is important. So to conclude, I think the lessons we've learned from the USA experience with screening has been that it can be effective, can reduce incidence mortality. As screening rates increase, cancer rates decrease. We have guidelines that have emphasized colon cancer prevention. We have demonstrated that in some settings, the obstacles to screening can be overcome, such that more than 50% of Americans now are getting some screening. And the effectiveness of screening depends on quality. So this is the sun setting at the Oregon coast. I hope that the sun is going to set on colon cancer in our lifetimes. Colon cancer screening can be effective if it's performed with high quality. Thank you very much.